I'm Representative Lisa Borowski, and I want to thank Chair Frankel and Chair Rapp for the opportunity to host this hearing and further explore the challenges faced by healthcare providers across our Commonwealth.
Hospital consolidation and closure has been on my mind for more than a decade as I watched hospital systems, particularly right in my own backyard, acquire small independent hospitals ostensibly to save them, then close ones that were in less affluent neighborhoods while building hospitals in wealthier areas. My community has also felt the way that these acquisitions get used as part of a broader economic strategy, creating leverage to use with insurance companies. And that's not resulted in, you would think that when you talk about consolidation results in lowering of healthcare costs. The opposite has been the fact. We've seen healthcare costs nationally, with this trend is national, escalate, and we pay twice as much as the rest of the developed world for our healthcare, and in fact get poor results for the money that we're paying. I believe that we all believe that the primary role of hospitals is to ensure access to safe care in our communities. I'm looking forward to learning how hospital financing and commercial transactions impact hospitals' ability to meet those goals.
Great, thank you. Chair Frankel and Chair Rapp and the distinguished committee members, thank you so much for the opportunity to speak to you today. I'm hoping you can hear me. Yes.
Yes.
Great. As you know, my name is Rachel Werner. I am a general internist and a health economist here at the University of Pennsylvania, where I have been studying healthcare sector and specifically the effects of healthcare payment and financing on quality and access for over 20 years. As you know, and as you said, the closures of U.S. hospitals has been accelerating in recent years, and it's been made worse by financial stressors from the COVID-19 pandemic, rising costs from labor, supplies, and drugs, and longer hospital stays. A common concern, as you've stated, is that the parallel trends of increasing market consolidation and also private equity investment is contributing to these closures. My goal today is to provide an overview of what research shows us about the effects of these market forces on hospitals, examining specifically how they affect hospitals' financial outcomes, quality of care, and access to care, including closure. So I'll start with an overview of consolidation. One of the most concerning trends that we see in healthcare markets today is decreased competition or market consolidation. Consolidation occurs when hospitals merge, often within the same market, though not always within the same market, which I will get to. Hospital mergers have been increasing over the past 2 decades, and as a result, the number of independent hospitals in the U.S. has declined significantly. Most hospital markets today are highly concentrated. There may be benefits, actually, to some of these mergers, including increased care coordination and reduced duplication of clinical services for patients, also reduced operating costs for the hospital. And indeed, hospitals and their trade groups regularly cite these reasons to merge. But consolidation decreases market competition and increases market power for the merged entities. And the effects of consolidation have been well studied. First, it's quite clear that hospital mergers increase commercial healthcare prices. Prices increase on the order of 20 to 30% are common, and they can reach upwards of 50% increases. It is important to recognize that the burden of these higher prices ultimately falls on patients through higher healthcare insurance premiums. The increase in prices is not surprising. It actually makes sense. Higher prices are the result of a hospital's increased market power after merging, and with fewer other hospital options in a given market, the ability of merged hospitals to use that power to negotiate higher prices from insurers. The effect of consolidation on hospital quality is more mixed by the evidence, but by and large, it suggests that quality of care is worse in highly consolidated markets compared to markets with more competition. Research has shown this to be true in the form of higher mortality rates, higher readmission rates, and worse patient experience of care after hospitals merge. There's really less evidence about the effect of hospital consolidation on access to care. The evidence to date does not support the idea that mergers lead to closures, and in fact, the opposite may be true. Acquired hospitals may be more likely to remain open than had they not been acquired. But mergers may still affect access through other pathways. One such pathway is if hospitals selectively admit certain types of patients after a merger. And one recent study found that fewer Medicaid enrollees were admitted to a hospital as markets became more and more consolidated. My prior comments in the review of literature has primarily focused on within-market hospital consolidation. However, it's worth mentioning the growth of cross-market consolidation, or mergers occurring between hospitals and health systems that operate primarily in different regions. A noteworthy recent example in Pennsylvania is the announced plans for Kaiser Permanente and Geisinger to merge. Like with within market mergers, cross-market mergers decrease competition and increase prices, despite the fact that they operate in distinct markets. This may happen in part because these mergers increase the acquired hospital's bargaining positions with insurers, which seek to have strong provider networks across multiple areas in order to attract employers and employees in multiple locations. I now want to turn to private equity acquisition and briefly address the impact of private equity on healthcare markets. Private equity investment in healthcare is becoming increasingly common, and in the past decade, private equity firms have invested nearly $1 trillion through thousands of deals to acquire hospitals and specialized practices across the United States. There are theoretical benefits to private equity investment in that it provides access to capital to support infrastructure improvements like IT systems and new facilities, and it leverages economies of scale and managerial expertise to help improve efficiencies within hospitals. However, there is understandable concern about the growing influence of private equity in U.S. healthcare, given private equity's focus on profits rather than patients and their short time horizon for return on investments. The evidence we have for private equity's effects on healthcare is much more limited than the more robust evidence that we have on the effects of consolidation, but this is what we know. In terms of financial outcomes, while media headlines report bankruptcy filings among PE-acquired hospitals, there really is not widespread evidence that private equity causes financial instability or hospital closure. In most cases, private equity investments actually improve hospitals' financial performance, with hospitals seeing increased operating margins stemming both from cutting operating costs and increasing revenues. What may be more concerning is the way in which hospitals achieve higher operating margins, which has included reducing hospital staffing levels to cut costs and increasing prices to boost revenue. There is quite limited evidence of the effects, good or bad, of private equity on quality of care. And in terms of the effects of private equity acquisition on patient access to care, at a patient level, there's no evidence at present that private equity acquisition limits patients' access to hospital care, though there are not many high-quality studies in this area. Likewise, there is no strong evidence that private equity acquisition causes hospitals to drop a hospital's unprofitable service line, such as labor and delivery. There is some evidence that private equity acquired hospitals do shift their focus from outpatient care to more lucrative inpatient care, which could reduce access to outpatient care. There is another aspect of private equity investment, which for me is a real cause for concern, and that is the effect of private equity on market consolidation. What we know in this area comes from private equity acquisition of physician practices, but may extend to the hospital setting. Private equity firms regularly acquire small physician practices. While each individual acquisition is quite small, the continued acquisition of additional practices in the same market causes consolidation over time. Because each individual acquisition is small, these acquisitions often escape scrutiny and so continue unchecked. As noted previously, this increased consolidation will likely lead to increased commercial prices with no positive effects on quality and potential deleterious effects on access. While the evidence of negative effects of private equity acquisition on hospitals is limited to date, ongoing monitoring of these activities and their effects is vitally important, given the profit-focused motivation of PE firms, which may not align well with the goals of improving patient health and outcomes or with investments in communities. To fully understand the effects of private equity in healthcare, we really need better transparency and reporting of private equity deals and the terms of those deals, which today are quite opaque to us. This would allow closer monitoring and accountability of the effects of private equity acquisition on hospitals and the patients in the communities that they serve. And so taking all of this evidence into consideration, policymakers considering approaches to stabilizing the cost, quality, and access in the state's hospitals should focus, I believe, on ways to address the dynamics that lead to high costs with little improvement in quality and access. They should limit consolidation and the activities that lead to consolidation. And in markets where consolidation has already occurred, which is many markets, approaches should focus on increasing competition where possible, preventing anti-competitive behavior of insurers, and possibly regulating costs. Thank you for the opportunity to speak with you today.
Sure, thank you. Really appreciate the testimony today. At the risk of maybe opening us up to kind of a broader discussion, we've seen consolidation taking place with facilities, physician practices, and we've also seen this phenomenon of integrated delivery networks. So now we have large healthcare systems acquiring other healthcare hospitals, physician practices, but also having their own payer. That is kind of like a So what is the effect of having these integrated delivery networks in this kind of context of consolidation that's taking place?
So I can briefly address some of that. The type of consolidation I talked about earlier is what we refer to as horizontal consolidation, when similar providers merge with each other. So hospitals merging with each other. What you're describing is what economists refer to as vertical integration, where hospitals integrate with other providers along the care spectrum. And so they might acquire physician practices, insurers might acquire physicians' practices or hospitals and create these integrated networks. Generally, the evidence of that kind of consolidation is quite similar to the evidence of the effects of horizontal consolidation or mergers and acquisitions. They tend to lead to higher prices because they are anti-competitive. They're anti-competitive in slightly different ways, but the evidence, although not as strong as what we see in horizontal mergers, is strongly suggestive of higher prices with vertical integration that you're describing.
I believe one of the observations today is that there is not enough competition among hospitals, and therefore, due to mergers or consolidations, you are seeing a rise in pricing. If I can give a quick summary of some of your comments, would that be correct?
Yeah, that's a great summary.
Frankly, I have heard somewhat the opposite, particularly in the Pittsburgh region, where UPMC and AHN seemingly have an arms race going, where they're building facilities right across the road from one another. And I know historically the thought has been that we are spending too much in the healthcare arena, that we have too much competition, and that it is affecting, obviously, the cost of healthcare when you have facilities competing, as we see in the Pittsburgh region. I just wondered what your thoughts might be on that particular approach, is that competition can sometimes be equally destructive of hospital systems, as much, if not more so, than lack of competition.
So thank you for the question. I think that sometimes it's very hard to reconcile what studies of national data show with local examples of what's going on in your own communities. I will reiterate that there is an overwhelming preponderance of evidence showing that competition is good for reducing prices and in some cases improving quality, mostly for people insured by Medicare. There are definitely exceptions to the rule. It's part of what makes these decisions difficult, is that each community is different from each other. I think that the Pittsburgh region is generally not a very competitive region as hospital markets go. It's dominated by just a couple of, really it's dominated by the Pittsburgh system, but dominated by relatively few healthcare systems. what you're describing, I think, has some implications for the impact of consolidation on access. And as I previously said, there is no evidence that consolidation reduces access to care for patients in most cases, and it doesn't really lead to hospital closure. I think that the medical arms race that you referred to is not a direct it's not a direct result of competition. It has more to do, in my view, with how benefits are structured and what we pay for through health insurance. Individual consumers are relatively insensitive to the price of healthcare because we're insured. So many of us have high deductible health plans, but once we go past that deductible, we're quite insensitive to the price of healthcare. So the medical arms race really, I think, has more to do with what insurers agree to cover than what the individuals consume, and also with direct competition in the market.
At one time, Pennsylvania had a certificate of need, where Pennsylvania was looking to regulate or lessen competition, that there had to be a justification for a medical need to construct facilities, so we didn't have an overabundance of medical facilities. And yet your comments today seemingly would not support a return to a certificate of need in an attempt to control pricing, because as competition is ramped up, you're going to see more money spent on more buildings, increasing necessarily the pricing for hospital systems. So I'm wondering what your thought would be relative to the prior system where you had to get a certificate of need to construct a facility. If that is something that you think we should look at, or if you feel like, no, let the systems go at each other, let them spend what they want to spend, and let them construct as many buildings, even though, frankly, they're going right across the street from one another. So
there are a few things that almost all health economists agree on, but I think the utility of certificate of need is one of them, which is that we should not return to a landscape in which we use certificate of need to limit entry to the market because it reduces competition. I want to be clear that the effect of competition on prices is not through building new buildings or building new facilities. As we know, there's a decline in the number of facilities and hospitals throughout the state. The effect of consolidation on prices is through insurer bargaining and through market power. And so if we want to affect prices, that's the lever that I think that would be more effective, would be to limit insurers' anti-competitive practices.
As a board member, we would periodically review the need for price increases. And frankly, it wasn't a very serious exercise because there was so much discounting occurring by the insurance carriers. They were really setting the prices for us. And then we had the government, which really failed our hospitals, particularly our small rural hospitals, in reimbursement for care that was being provided. If we would be paid by the government at market value pricing for our small rural hospitals, frankly, we would not have merged. The inability to recruit physicians to rural areas and the failure of the government to pay its fair share for medical care. The discounts were frankly much larger than what I have seen in the documents presented to us today. I think it was 80% for Medicaid. I was surprised to see Medicaid was paying at 80% of the cost of the service in the hospital. I thought that was an overly inflated number. But I'd like to hear your comments as to whether you think that the failure of the government to meet its burden is driving small hospitals and driving mergers, not only in Pennsylvania but across the nation.
So I will give you a brief answer, but I also want to defer to Dr. Chatterjee, who is going to testify later on this morning, who has a real expertise in this and is going to talk a lot about how payment can affect these matters. Medicaid, on average, pays less than Medicare commercial prices for hospitalizations and for all other services. It's quite variable across states, and actually, in some states, it's much more equitably distributed across Medicare and Medicaid than in others. Hospitals that care for a disproportionate share of Medicaid-insured individuals have worse finances than hospitals that care for fewer Medicaid-insured individuals. Those lower finances certainly lead to lower quality of care, lower staffing, increased likelihood of closure, decreased access to care, and a whole slew of problems for individual patients. The effect of consolidation on that is really unclear. So there have been cases where large hospital systems do these cross-market mergers and acquire either rural hospitals or safety net hospitals. Whether or not that is bad for those hospitals and the underlying finances of those hospitals and the quality of care in those hospitals is really unclear. Many of those hospitals live in a very precarious financial position, and having outside funding to help keep them open may actually prevent closure in some cases, but we just don't know enough to say for certain what the long-term effects are. Dr. Chatterjee has much more to say on this than I do, though.
I'll be super brief. I represent Western Pennsylvania. In the city of Pittsburgh, most all UPMC hospitals are in my district. I also have Allegheny Health Networks, West Penn Hospital in my district. As a long-time healthcare access and reproductive justice advocate who's worked with organizations like FAN, this is a critical conversation. As a legislator and also as a mother, my partner and I just had a baby 6 weeks ago. I'm actually not here. I'm still asleep from my many sleepless nights. But I am deeply disturbed by the maternal mortality rate in Pennsylvania that is 2 times higher for Black mamas and birthing folks. And I'm wondering, how does consolidation and closure contribute to the Black maternal health, public health crisis, as well as maternal deserts when hospitals consolidate and close? And so Dr. Werner, in her page 2 of her testimony, she says, you say that as hospital markets become more consolidated, fewer Medicaid enrollees were admitted to the hospital compared to overall number of patient admissions. The effect was particularly pronounced for labor and delivery admissions, the most common reason for Medicaid admission. So if you could briefly answer a question or give us some insight on how consolidation and closure contributes to disproportionate health outcomes around maternal health, maternal mortality, and maternal morbidity that is impacting a lot of our rural counties across the Commonwealth.
Sure. So the article that you just cited is really hot off the presses. It was just published this month, and it was the first piece of rigorous research I've ever seen looking at the effect of consolidation on access to care, showing the decline in Medicaid admissions for Medicaid individuals to hospitals, particularly labor and delivery. And so I agree this is of paramount concern, and it is an area that we need much more attention paid to. I think that given, as you say, the high rates of maternal morbidity and mortality, particularly among Black individuals, this is an area that deserves much more attention, and ensuring good access to high quality care, labor and delivery care, I think is one of the highest priorities for us as we consider how to address consolidation in this area.
When I remember growing up, we had a ton of hospitals in Philadelphia. I remember we had general hospitals, and I'm wondering, has the die already been cast? Is it too late to go back to, granted, we may not need as many hospitals since we're able to do things a little differently now, be more efficient, keep people in the hospitals less than they need to be, less time than they need to be. But clearly, I think there's an issue of access to care. Are there other policies that other states are doing to sort of increase competition, other models that we should be looking at? Thanks.
Sure. So great to see you, Representative Khan. I want to make a few points. One is, which you alluded to, the rate of hospitalizations in this country is declining because we're doing more and more care in outpatient settings. And so what the right number of hospital beds in this country is a little bit unclear. And so although we've had some closures, and we believe that that's too many closures because we've created deserts, there are other areas of the country where we probably have too many hospital beds. So it's hard to get this exactly right. Once hospitals are merged and once there's consolidation, it is really, really hard to unwind that. And so most people focus their attention on efforts to decrease anti-competitive behavior rather than trying to actually improve competition with new hospitals and new hospital beds or undoing mergers. There are a lot of states who have had experience doing a number of actions to try and improve competitive behavior. Some of them are related to transparency of information. So improving the transparency of hospital price and quality information can improve consumer choice of hospitals and competition that way. And that is ongoing effort on both at the federal and federal level and in many states. States can also regulate insurers who and prohibit anti-competitive practices. So this can prevent insurers from providing, so often insurers don't provide information to enrollees about more or less expensive providers or make it difficult for individuals to find lower cost, high quality options. These are often called anti-tiering, anti-steering, or gag clauses. States can prevent those kinds of clauses in insurance contracting. States can also, the FTC obviously reviews, before mergers occur, FTC obviously reviews them, but a recent review of state antitrust enforcement identified other practices that can support that robust enforcement, including adequate notices of potential mergers and waiting periods for states, and establishing criteria for merger review and the ability to conduct a full analysis of the economic and care implications before the mergers occur. And so I think there's a number of avenues that states can take, both to try and prevent further consolidation and also to promote competition once consolidation has already occurred.
Thank you all very much. I really appreciate your being here today and your thoughtful testimony. Thank you.
Thank you.
All right, we're quickly going to move to our third panelist, Dr. Paula Chatterjee, Director of Health Equity Research at Leonard Davis Institute of Health Economics at the University of Pennsylvania. She will be talking with us today about alternative payment models to support struggling hospitals. Dr. Chatterjee, thank you for being here and welcome.
Thank you so much. Good morning, everyone. Thank you for the chance to be here. I understand and have an eye on the time, so I will try to keep my comments brief to allow for as many questions as possible, and I'm happy to entertain any questions from my written testimony, which will cover most of what I'm speaking. So, you've really heard this morning a broad overview about hospital consolidation, private equity, and closures, both throughout the United States and in Pennsylvania. And we've also discussed some of the regulatory options. My testimony is going to try and build on this foundation and focus on paths forward, specifically as they relate to hospital payment, which is a topic that I think has sort of been percolating through all of the discussion today, but I'm going to try and be specific about that. Particularly, I'm going to go through 4 current policy options that have been brought up really within the past 5 years that have either the implicit or rather explicit goal of ensuring hospital financial viability. Some of these are very familiar to you all, in which case I will try to be especially brief on those, and others are rather new, and I'll go into as much detail as available. So I'm going to start by talking about the Pennsylvania Rural Health Model, which of course so many of you are familiar with. Beginning in 2019, rural Pennsylvania hospitals were able to participate in this model, which assigns a global budget to hospitals that is agreed upon by all the payers within the state. And really the goal of that policy is to provide these hospitals with financial predictability. They give them the predictability to allow them to make investments in their care infrastructure and meet patients where they are. As I mentioned, this began in 2019. To date, 18 rural Pennsylvania hospitals have elected to participate in the model. I think we have some early evidence that suggests that the global budget has been financially stabilizing for these rural hospitals. Of course, the implementation of this program coincided rather well with the COVID pandemic. However, there have been growing concerns about the sustainability of this approach, particularly from the standpoint of payers. It's been even harder to tease apart the effects of the rural health model on patients. Has it really achieved its goals of improving access, improving quality, improving the management of chronic conditions? Analytically, I won't go into the details, but it's been rather hard to tease that apart because of all of the different moving parts in the state, but it's something that we're working on. What we do know is that we have evidence from other global budget demonstrations around the country, particularly in Maryland. And what we can say is that the effect of Maryland's global budget for hospitals has been somewhat middling when it comes to patients. At least within the first 2 to 3 years of the program there were no real associated changes in hospital use, primary care use that were really clearly attributable to their global budget program. And so I think, it's a bit early to tell in terms of where the Pennsylvania rural health model will ultimately fall out. And I know this is, of course, within the context of CMMI indicating potential early termination of the program. Some of the reasons behind that termination are sort of related to the fact that the model builds in cost savings goals. And that's a really hard thing to achieve for a rural hospital that is so concerned with, keeping their margins afloat. To allow them to be viable. Really trying to bundle in a cost savings goal is really a hard piece of math to figure out. I think there are some other challenges with the Pennsylvania rural health model that have come to light, which are that stabilizing cash flow alone might not be a sufficient incentive to really move delivery system transformation in the way that they need it to move. And so I'm happy to talk more about that if we have time or questions. So that is policy one. Policy 2 is another policy that is specific to rural hospitals. It's CMS's Rural Emergency Hospital Program. This is something that is open to rural hospitals nationally. And so it was established in 2021. And the idea was basically to say, we understand that rural hospitals, specifically critical access hospitals, have a very hard task to achieve. They have to sustain costly inpatient care services when they're struggling with perennially low occupancy rates. And that, again, is very hard math to achieve. So what the Rural Emergency Hospital Program says is it says a rural hospital can elect to be a part of this designation. That hospital will then cease all of its inpatient operations and really convert to what's kind of like a freestanding emergency department, so that emergent care services will be preserved along with a variety of observation care and some outpatient services. But really it takes the onus of keeping an entirely functioning inpatient service line away from rural hospitals and says you can operate as an ED to preserve access to care, to timely care that's most needed by patients. The hospitals could start participating in this program in 2023, but what I will say is that very few nationally have indicated their proclivity to participate. And that's mainly because they're not sure whether the funding associated with that program is going to be sufficient to allow them to make these rather dramatic service line changes. So hospitals that do end up participating in this program are going to get a 5% add-on from the Medicare program for their outpatient payment rates. They also get a new facility payment, but whether that's enough to really scale up the services that they need from an emergency standpoint, a telehealth standpoint, an obstetric care standpoint is not clear. And so there haven't been that many participants yet. Third model I want to briefly mention is something you may have heard from CMS called the AHEAD model, which stands for Advancing All-Payer Health Equity Approaches and Development. This is a very nascent model just introduced in September last month, and the goals of which are still evolving. But I think that the way that I'm conceiving of it is that CMMI is trying to sort of achieve 3 goals. They're trying to ensure financial viability for hospitals, again, through a global budget approach. They're trying to promote investments in primary care, and they're trying to support beneficiaries' connections to community resources. The way that they're going to do that, I will confess, is very nebulous at this point, but those are sort of the broad overarching goals, and I'm happy to talk about the details of that if anyone is curious. I just wanted to mention it given that it was recently introduced just last month and specifically focuses on hospital financial viability through the mechanism of global budgets. The last policy I want to mention involves the creation of what are really sort of these state discretionary funding pools that are designed with the express purpose of ensuring hospital viability. And so 2 states have taken up this approach, New York and California. New York basically established a funding pool that will be allowed to provide temporary operating assistance to financially distressed providers. This often means hospitals that have had negative operating margins for the past 2 years, or hospitals that don't have assets or resources to maintain their operations, as was discussed previously by the Attorney General's office. California has established a similar program, albeit a bit narrower in scope. They have something called the Distressed Hospital Loan Program, which focuses specifically on nonprofit hospitals, publicly operated hospitals that are in financial distress. And they basically offer an interest-free loan that is payable over 72 months. So in some ways, I like to think of these discretionary pools like we think of other sources of supplementary funding, such as the DISH payment program, the upper payment limit program. And while those programs are wonderfully flexible to meet the needs of specific hospitals, they also have the unfortunate trade-off of opening up opportunities for funding mistargeting. And again, I'm happy to talk about that as well. But I know that was a bit of a whirlwind. It is 10:56, so I will stop. And I'm happy to entertain any questions. Thank you again.
Great. Thank you very much, Dr. Chatterjee, for that very quick and very thorough testimony. Do any of my colleagues have any questions? Oh, Chair Rapp. It's Chair Rapp. Thank you.
Thank you, Madam Chair, and thank you, Doctor, for being here today. You mentioned that New York established the Hospital Vital Access Provider Assurance Program. You may or may not know that we have pending legislation in Pennsylvania modeled loosely after what New York has done. What have you seen in terms of success or failure with the program in New York State?
Thank you so much for the question. Given that the program was just introduced in June, I think it's a little bit early to tell in terms of what its potential successes and pitfalls might be. One of the things that did strike me about New York's program is the tremendously generous eligibility criteria for hospitals that are allowed to apply for the funding. So it's not just public hospitals and critical access hospitals and sole community hospitals. It's really almost any hospital in the state that can make a case to them that would be eligible for this source of funding. The other part of the current New York program that I would like to see more detail on is sort of their specific definition of financial distress, which has already been raised today. Right now, they're sort of limiting it to hospitals with negative operating margins for the past 2 years, or those without assets or resources to maintain their operations. What I find a little tricky about that is that we have recent evidence that shows that there are, specifically in rural areas throughout the country, there are hospitals that are in yearly financial distress that stay open, and there are hospitals in yearly financial distress that close. And we're still not quite sure what the reason for that bifurcation is. And so I think sort of getting a little bit of clarity on what a negative operating margin means for the trajectory of a hospital and seeing if it could be built into the eligibility criteria is something that I was curious about.
Okay, great. Dr. Chatterjee, thank you very much. We appreciate it, and we'll certainly be rereading your testimony, so thank you very much.